لازم we have to test the technology is it working or not. أولاً شكراً للدكتورة ندى. الدكتورة ندى whom doesn't know, الدكتورة ندى is a clinical pharmacist. She is working with Cchi as a senior advisor for EBB and essential benefit package and insurance drug for malaria. First of all, I'd like to welcome you all to this important event. Cchi, or Council of Cooperative Health Insurance, is looking forward to continue partnership with all of you as a main stakeholder on how can we improve our population health. Cchi mission and vision, which was approved by our board end of 2019 and launched at the beginning of 2020, يعني موجود أبو جراح هو أحد أعضاء مجلس الإدارة الدكتور خالد السبيعي، تشرف فيه اليوم كممثل لمجلس الإدارة وكذلك كممثل للقطاع الخاص. I think we need to speak in English. We have two people who cannot understand Arabic. So since the beginning, actually, our board direct us to focus on prevention. And our mission is not really to create only prosperous health insurance, is really to create or to improve population health. That's why our strategy and our vision and mission are fixated around beneficiaries. I will just start with macro picture. If you look to the population of Saudi Arabia today, we have around 34, 35 millions. Now I think we are going in the process of creating another stat updates, and I'm sure the growth will continue. 30% of them, or 33%
Recording in
of them,
progress.
are having a private health insurance. What does that mean? Private health insurance by private employer. And we think by 2030, as you can see in the background, we will reach 21.7. It's a journey. It will take us some time, but that's a sign of continuous growth for the market, for the economy. And there is several reasons why we are going to that direction, because our economy is primarily now based around the private sector. So we would expect a lot of growth in the private sector. That means a lot of beneficiaries. That means a lot of insured population. By 2030, we think we will reach 55 million, 55% of our population in Saudi Arabia do have a private health insurance. And I'm sure our PRB, or Figure Realization Program, is also working on the governmental coverage or the public coverage. If we go to the next slide, what is the validation of these numbers? Are we bringing these numbers just for the sake of the numbers? No. In 2010, we were having only 3 million population who are covered with private health insurance. Now we have 11 million. That means we triple over 10 years. And that's a sign of proof that we will continue to grow over the upcoming 10 years, inshallah. The Figure Realization Program is an essential tool to help us to work together. And I'm sure most of us here are represented in the Figure Realization Program, and we are obligated to adopt the three main pillars of the strategy. One, how can we improve access? How can we improve value for care? Or how can we adopt value-based healthcare, which is تعزيز جودة وكفاءة الخدمات الصحية? And third thing, how can we focus on prevention? That's why value-based healthcare is very much linked to population health. We cannot improve people's health unless we adopt the tools and the mechanics to improve health. And value-based healthcare is a new science. It's evolving. It's really simply, it's the outcome of the healthcare services, either from quality point of view or from satisfaction point of view or from experience point of view, divided by the cost. And I'm sure if we adopt the mechanics and the tools and the digitalization that we are embarking on, I'm sure we'll be reaching there. That's why I'd like to welcome you all. We need to brainstorm together today to think together how can we improve those 11 million population health. those who are gonna grow over the upcoming 10 years, what we need from infrastructure point of view, what the needs of collaboration, how can we improve the value? Because remember, the payer for the policy in private health insurance is the employer. And the employer is the engine of the economy. We need really to make sure they have a value in exchange for their service. If the government now, who has the deep pocket, is reforming the healthcare for public people, I think the private sector deserve from us, we give them an affordable policy that they can pay, they can expand their business, doesn't prevent them from shying away from hiring more people. And that's why population health is very much linked to that, because it's really focusing on the outcome, on the value. So without any further ado, I thought I need really to just give you this introduction, and I'm sure we have a lot of expertise here who can really shed a lot of lights on a lot of area. And I thank also Dr. Nahar, Dr. Ibrahim, also other guests who joined us today and support this event. Thank you very much.
Assalamu alaikum wa rahmatullah. Good morning, everyone, ladies and gentlemen. Very happy to have you with us here today. This project has been on the kitchen for the last maybe at least 24 months. With the introduction we had from Dr. Shabab and the direction we had from our board and the whole transformation happening in the country, we know for a fact that today in the health, around the health sector, that there is a rising increase in cost. And this cost is something that we have to take care of. And looking into other countries in the world, such as Netherlands, which we think is one of the countries that applied a very nice controls over the value-based healthcare initiatives. We've looked into a number of interventions that might be applicable for the Saudi market, which is those in red, and whether or not those can be applied to our health ecosystem, in particular to the private health insurance ecosystem, and see if, hoping that this would control the rising cost and provide a better value to our population. We have used this slide from our colleagues who worked in the health transformation program, that they were saying that without applying the proper interventions, that they have forecasted about savings of more than 40% on pockets of integrated care, population health management, and digitization, which I believe Dr. Al-Mandil today is there in at a better position to speak about this global or health transformation program. There will be an issue, and we believe that those interventions as part of the transformation members are applicable to in the healthcare or private health insurance ecosystem. Looking into, again, the vision of the country, capitalizing on the transformation happening, and also factoring in the objectives of two major programs, the health sector transformation program, the financial sector development program. We wanted to create a strategy to this project, which materialize into crossing with other entities such as Saudi FDA, Wiqaya, the Saudi Health Council, and the other major players and regulators within the market. And the next slide, those are Yeah. So if you look into those in particular, you can see that promoting prevention and care, in addition to promoting the use of primary care, and the other initiatives are very well integrated within our strategy in CCHI. And also highlighting that our population is growing, as Dr. Shabab mentioned. And we are talking about or envisioning around 22 million in population. So how can we have a better population health management programs for the privately insured population? How can we enhance primary care? How can we also capitalize on mechanisms such as pay for performance and play as a orchestrate that within the different objectives of the regulators. So I would also shed the light on the next slide on the ecological perspective of our population. So you have the beneficiary, and then there are high-risk beneficiaries, which maybe contribute to 20% of the total population, but however, they may consume 80% of the spending on health. And then how do we identify them out of all of the beneficiaries? What's the role of the payer and the provider? And then how can CCHI help enable those different players? And then how can we factor in the central bank objectives, and how can we have a better financial performance? And then also, how can we factor in the objectives of Ministry of Health, as both they license insurance company and providers? And then how can CCHI go there and try to integrate and get a better value for our beneficiaries? So the team has become with a goal in improving the population health for privately insured patients for the next 5 years. And we say that this is going to be using the concepts everybody knows here as the value-based healthcare concepts. And by focusing on the 5 major diseases, and which has a higher burden and cost, and also these are, as you see, the coronary heart diseases, the hypertension, diabetes, obesity, and tobacco-related diseases. The strategies that we would like to capitalize in is how can we again enhance primary care, so access to care through primary care centers. Then how can we capitalize on the market maturity and the capacity that is there? And then how can we promote population health management? And I think Dr. Lamar is going to shed some light on what's the difference between public health and population health, and then how can we drive innovation. We thought of putting this into a strategy house just to illustrate what we think is our North Star is. There are 4 components which act as pillars to this program, such as enhancing primary care, population health management, and then pay for performance strategies, innovative care models. And then we need to lay those pillars on a very strong foundation, such as the essential benefit package, which is the benefits that the market players or the market stakeholders can use. And then how can you also leverage the access to medicine, which, by the way, contributes to more than 30% of the cost within our ecosystem. And then how can we capitalize on digitization with the use of Nafis? Today we have a very nice opportunity to have a unified platform that can monitor all the transaction in terms of financial transaction and also health transaction. And then we need to put in mind that we have a rule of engagement in terms of quality controls. So we don't want to be driving the market without defining what's the quality standards that we want. So there is a strong program which is the payer and provider qualification and accreditation standards, which will help in rating our providers and payers and defining their quality deviation with the help of other regulators in the market. As you have seen here in the slides, there are some of those initiatives that have been realized already in green. And then some of them are in phase 2. So we are trying to use a phased approach in order to achieve our initiatives and an objective. And then in phase 3 are things in red. We believe that we're going on this direction, and with the help of a few today, and thank you for showing interest of being part of this event. Hopefully, inshallah, we will achieve our objective. Maybe if I can give the floor or leave the floor to my colleague, Dr. Lamar, who has been, he played a material role in building up this project, and he's going to shed some light on other part of the program. So, Dr. Lamar, I will leave the floor for you. Thank you very much.
Okay. Good morning, everybody. So before I get started, I just wanted to thank a few folks. I want to thank Dr. Shabab, first and foremost, for his leadership, but also for pressing us and really challenging us to really put our best ideas together. And that's what you're going to be seeing here today in putting this roadmap together. I also want to thank and recognize Dr. Uthman for his support, for his leadership over the last 15 or so months that I've been here on the team. And then I want to thank someone that you already have met, which is Dr. Nada, who's been really working tirelessly behind the scenes to bring us to this point and get us to this presentation today. So thank you to all those folks. So thank you all again for joining us. I'm Lamar Hasbrook. I'm a senior consultant, and I'm going to try my best to take the next 20 minutes and walk you through about a year's worth of work in building this roadmap that the team has been very involved in doing over the last few years, or over the last few months, 12 months or so. So I start with this slide because there's a saying that if you want to go fast, go alone, and if you want to go far, go together. And so we've been really working to have engagements such as this and others to really have a robust stakeholder engagement along the way. So we've been meeting with, a number of the key players in this environment and really socializing them and getting their best thoughts and helping us to refine this strategy and this 5-year plan roadmap going forward. So that's important to note, and we plan to continue to do those things as we continue to roll out this phased approach of the strategy. So we have a couple of challenges if we want to transition to value-based healthcare and if we want to improve the population of the private beneficiaries. That's the population that we're concerned with, that we have the most influence over. Challenge one is that we have suboptimal population health, or suboptimal health of this population. I don't think anyone would argue with that. If you look at the 10 leading causes of disease and disabilities, you'll note that of the 10, many of them have to do with non-communicable diseases. And you have your stroke showing up, your diabetes, your heart disease, things that we all know, that we all see in practice. But also if we look at those risk factors that really power or undergird these things, we see that they are the lifestyle conditions that we all have to grapple with. So we see those things like high blood pressure, body mass index, prediabetes, things like that. So it's important that as we begin to try to transition, that we focus squarely on those things that are driving costs and driving premature death, premature illness, premature hospitalization, and all the other health outcomes that we'd like to address. So when we talk about our 5x5 and the 5 conditions and diseases that Dr. Uthman has outlined, it's really a very logical approach. We're really focusing on the high burden, high cost conditions in the universe of things that come through the door of a clinic or that we have to deal with in terms of trying to improve the health of a population. There's those things that are very common. Some of those cost a lot. Some of those don't cost much at all. And there's those things that are uncommon. And so if you look at this 2x2, we don't have to focus on those things that are low prevalence and low cost. Those will take care of themselves. Perhaps we want to eventually look at some of the other quadrants, quadrant 1 and 4, but really we want to put our investment over the next 5 years in those things that are both high burden or high prevalence and those things that are high cost. Because if we can reduce those, we can reduce the entire trajectory of the cost of the expenditure and obviously improve the health outcomes of the population. And so that's why we picked the 5 conditions, and I think it makes good sense. So challenge number 2 is that the healthcare expenditure is reeling out of control. It's unsustainable, not only here, but in many countries, as you can see. We don't know what the estimated waste is, how much we're actually wasting in Saudi Arabia. But we do know, by looking at international benchmarks, there's a lot of waste out there. How much waste? Somewhere between 20% and 30% of the healthcare spend is wasted. And so that's challenge number 2. So when we talk about value-based healthcare, we're really talking about quality over per capita cost, and that's the value. If we can get better quality, better outcomes, better safety, better patient satisfaction and experience at a lower per capita cost, we're hitting the mark on achieving value-based healthcare. Well, we can't do that if we're wasting 30% of our healthcare spend. So that's challenge number 2. Now, when you look at where is this waste, how are we wasting this money? Well, let's look at the far left. You see the bar diagram. It says there's necessary spending, and then there's that wasted spending, 20 to 30% of spending. Well, there's been a lot of studies. This study happens to be from the U.S., and it looks at, it was published in JAMA just a couple of years ago, and it looks at buckets or areas of waste. And this study has been done for decades, and so they've kind of updated it recently. I think it was published in 2019. But the categories of waste are unnecessary services, duplicating tests, things that you don't really need, things that we might consider low-value care or over-treatment, administrative cost, inefficient care delivery, that is using protocols and treatment that may not be evidence-based. And so that waste up to 77%. Inflated prices, fraud and abuse, which we're all trying to fight, and then prevention failures, not taking opportunity of those prevention opportunities and coordinating care, so folks are falling through the cracks. And so if you look at the 6 buckets, 3 of those 6 buckets have to do with failed care. So 40% of this waste of 20 to 30% is due to failed care. So obviously, yes, we have to address costs, we have to address fraud and abuse, we have to address administrative costs, which we're all tackling at CCHI from our perspective, but clearly we have to focus on the lost opportunities in care, and that's really what this initiative or this strategy is built around. So what have we done at CCHI? We said, well, let's just take those 6 buckets and figure out the programs and projects and initiatives that we're doing on the left-hand column, from the essential benefit package to clinical practice guidelines you'll hear about today, to NAFES, to IDF, which you'll hear about today, enhanced primary care and other things. And let's align them with how we can target these areas of waste. And what you'll see just from a glance is there's a lot of tick boxes under care delivery, over-treatment, and then there's some in the area of care coordination. So again, it brings it all together. If we want to really move to value-based care, we have to put our investment here, and we have to align the initiatives and things to tackle and address and reduce these causes of waste while improving the outcomes that we all seek to have. So I'm going to run you through some of the areas that have been represented in the strategy house that Dr. Uthman walked you through. Some of the things we're doing, you hear a lot about this in our discussion this afternoon. So one of the things that we've been doing is trying to address clinical practice guidelines and protocol, moving the field, moving the sector to evidence-based care. There's things that we know if we do, they're going to result in better outcomes and reduce cost and reduce all that low-value care, over-treatment, extra treatment, things we do intuitively that may not make any sense or may not really improve the outcome of the patients. So what we've done under Dr. Hadi's leadership is we've gathered from international sources and national best practices here a number of clinical practice guidelines and protocols. We vetted them as a medical consulting team. There's about 12 of us. And we've looked at them in terms of the adaptability for the kingdom, looked at them in terms of the use, and we've come up with, I think we launched about 25, up to 25 now, but here represents some of the areas. So you see chronic diseases, the lifestyle diseases in bucket 1 and 2. Again, 5 by 5 is represented there. There's protocols or clinical practice guidelines around family planning, mental health, and other things. And that's an ongoing process, and we've been doing it in conjunction with a lot of the stakeholders that are listed down below. We've had, some seminars to introduce this, and we continue to get feedback. And eventually, we want to have an evergreen source of clinical practice guidelines that we vetted, that we endorse. There's others out there, but here's the ones that we vetted, we endorse, and we want to make sure the sector is using these things. Why? Better outcomes, lower cost. And that's one of the projects or initiatives. Another thing that we've embarked on doing, we know there's been a national diabetes registry here, very successful over the last, 20 years or so. We said, well, what if we take all of this rich data that we have today and the data that we're going to be getting from the fees, claims data, et cetera, and let's create some registries, some national registries for our population, the privately insured populations, on these 5 conditions of the 5 by 5. So diabetes, heart disease, hypertension, obesity, and tobacco related. And so we've done some work in putting this together. This is a real dashboard that we've created. We've started with diabetes and hypertension. And so we believe that with these registries, we could aggregate the data that's happening in these now 11 million, but soon to be 22 million beneficiaries, and really see by demographics, by region, by insurer, how well they're doing in managing these over time. And we can use these to track the prevalence, the hotspot where we need to put the additional investments, benchmark insurers against each other, who's doing the best in managing diabetes, who's doing the best in managing tobacco and measuring smoking, predictive analytics, business intelligence, priority setting, and the like. So this is an ongoing project, and we've done some data validation. And again, we're working with diabetes and heart and coronary heart disease and hypertension to start with. But what we're noticing, for instance, a project like this has a lot of secondary benefits. And what we're noticing is that a lot of this data is not being collected. Okay, so we know we have the minimal data set, we know we're moving towards ICD-10, and we got to improve our data standards. But for tobacco, in terms of who's measuring and asking their patients, are they smoking, documenting in that chart, in terms of some of the obesity things around counseling and weight loss program, that's missing. So a registry project like this can not only help us to do the hotspotting and things we need to intervene, but also help us in terms of building up our data standards and our data integrity so we can measure these things over time. So that's another project or initiative. Another one is kind of looking at enhancing primary care. As you know, the Health Sector Transformation Program, one of their strategies is to make primary care more visible, more used as a first stop shop. We know that these models work internationally, and Dr. Nasser, who is, I don't see him on the panel, but he should be there. Oh, there he is, okay. Yeah, he's been leading our work in this, and you'll hear more about this in the Q&A as well, but really advancing to kind of a team-based primary care physician-led approach, which is really elevating primary care, kind of an advanced model of primary care that has a number of things under one roof, so to speak, under one shop. Safety and quality, screening and prevention, population health management, which we'll learn more about in a minute. Virtual care coordination, so folks don't fall through the cracks and we don't waste opportunities and waste the opportunities for folks to get better because they're having a hard time navigate the system and moving to a specialist and back to the primary care doctor, et cetera. Integrated systems with different levels and different tiers of care, all based on a very robust and well-working electronic medical record. So that's the idea of a certified kind of patient care center. Sometimes it's referred to as a patient-centered medical home, and you'll be hearing a lot more about this. The Minister of Health has been very interested in this, and we have some meetings with him directly to help inform him of the work that we've been doing. So that's another piece of the puzzle. Then we talk about health Population health management approaches. Again, it's not the same thing as population health, and we'll get into this. It's not the same thing as public health, but it really is at the small level, the micro level, at the clinical level. It's the business, and sometimes it's referred to as population medicine. But it really is what happens at the clinical level for certain populations that you've identified. And usually you identify these on an enterprise-based approach. That is, who's costing us money? Where's the problem at? And how can we aggregate these folks and really give special attention to them? So it starts with defining the segment target population. It can be your diabetics, it can be your high utilizers, it can be your bounce backs, it can be whatever that you see from an enterprise perspective, running up cost. And then using evidence-based programs, there's that term again, evidence-based programs, to really engage them and customize the care that those folks in this specific discrete population really need. So sometimes that includes engaging them with apps or having different software so you can manage both the clinical data and the cost data. Coaching, analytic tools, care coordination is always a very important part of population health management. And then lastly, really tracking the outcomes for that population over time as an aggregate. So all your hypertensives, all of your diabetics that have their hemoglobin A1C out of whack, those are a special focus. And so the outcome measures that we're usually interested in, utilization, who are the folks going to the ED, who are the folks with these unnecessary hospitalization, and how we can reduce those through this program. Clinical metrics that you might choose, their weight loss goals, their blood pressure control, how engaged are they with their care coordinator? Medication adherence, you can have a whole population health program, population health management program around medication adherence, supporting them and giving them the tools to make sure they're taking their high blood pressure medication, et cetera. What's the cost of care, ROI, and the return on engagement? So those are some of the outcome measures. So just to give you an example of how this might look, if we look at some of the conditions or risk factors like diabetes, and we look at the prevalence in the country, 14%, the fact that it's increased over the last 10 years by 53%, then we can match that population, if we wanted to, with evidence-based programs that really tackle that. So lifestyle programs, things around nutrition, all customized for this discrete population of diabetic patients. Again, hypertension, low-cost medication, co-payments, fixed-dose medications, self-monitored blood pressure. Those are all customized, evidence-based programs that would be a part of your population health management strategy for this population of hypertensive patients, and et cetera. So that's another tool to improve the health of the population. It's a population health improvement tool. It's not the same as population health, but it's a tool under that umbrella. And then, of course, we will hear more about the insurance drug formulary. And this is just a slide to represent why focus on that. What are some of the benefits of that? Well, if we looked at, let's say, the U.S., for instance, as a default, most of the prescriptions that they're writing or that patients are filling are generics, 85%. When you look at Saudi, it's just the opposite. It's a very small portion is generics. Most people want the branded. Okay, obviously branded drugs are more expensive than generic drugs. So when we talk about a cost driver, when we talk about the expenditure on the right, 21% of the healthcare expenditure being medication cost, well, by moving to an IDF, we can reduce those medication costs and still have the effective outcomes that we need. And then we can identify even further through a population health management program, those folks who are non-adherent, non-compliant, and give them the special tools that they want, as some of the larger insurers are actually doing. Now, in order to hold this all together, and we're wrapping up here, in order to hold this all together, we have to have standards for the sector, standards for the market, for both the payers, our private insurers, those 24 or so companies, along with their TPAs, third-party administrators, and the providers that are out there working jointly with us to take care of the populations that we are focused on, that we care for, and that we have influence over. So what this slide is meant to show is that initially and basically right now, for the payers and for the providers, there's what we call our core standards, things you got to do to kind of play in the sandbox. If you want to work with the private patients, privately insured patients, there's certain standards that you have to show to us as the regulator that you're doing, that you have in place. And so year one, we're basically where we're at, and Dr. Hossam will talk more about this in detail. So things like a revenue cycle management, patient rights, things like that. So this first column, year 1. Year 2, year 3, year 4, and into year 5, we're going to be adding, again, a phased approach, as Dr. Othman mentioned, adding additional standards that help to support and enable the sector, both payers and providers, to move in the direction that can help support this bold initiative. And so you're going to have additional proof of documentation. You're going to have to engage in additional things in terms of managing your beneficiaries and in terms of managing the patients going forward. So just a big picture view that we're phasing this in. We're not going to shock the system and say, okay, tomorrow you got to do all of this when you're used to doing something else. So that's the point there. And then, importantly, there's a scoring matrix that you'll have. So when you submit all of your documentation and it's reviewed by our team, and perhaps a site visit might be necessary, may not be necessary, depending. We have a supervision and enablement team under Dr. Othman. We will take and aggregate all that, go through all that, and give you a score in terms of how compliant, how ready are you to really move in this bold direction. And we'll score you in these different tiers. You can be a learning organization or provider or insurer, all the way up to a market leader, which we'll recognize in different ways. Importantly, once we have a score, then we can actually liberate the score, so to speak, or make it public facing. And so now we have a benchmarking. So as you as a consumer, as an individual, or as an employer looking to do business with an insurer or in business with a certain provider network, you can say, well, how well are they doing? How well are they scoring? Are they a market leader? Let's go with them. It might be a little more expensive, but we're going to get more in the way of the outcomes that we want. So that's the idea. And I know the Ministry of Health has been really working on looking at a kind of a scoring and a rating system that's publicly known or publicly viewed to help make informed decisions and to encourage and challenge folks in the market to do better, to get where they need to be. And on the other side, there's clinical effectiveness measures, and we like to look at them as building blocks. Again, not trying to shock the system, but we got our 5 along the bottom: diabetes, high blood pressure, coronary heart disease, obesity, and tobacco. And they're color-coded. So for instance, if I was to look at high blood pressure, there is really one KPI, one clinical practice indicator that we want of folks, even over this 5 years. And that usually is, are you measuring the blood pressure regularly and putting it in the chart? Or is the blood pressure controlled? What percentage of your patients have their blood pressure controlled? If you look at something else like, let's say, diabetes, we'll start with one measure, one indicator, and then over the years, we'll add to that, add to that, add to that. And these are all very standard measures, HEDIS measures you're all familiar with, health effectiveness, data information system sectors. And it would look something like this. So if you look at high blood pressure, the percentage of your patients that have blood pressure controlled, less than 140/90. And you're doing that for the entire period of the 5 years. Diabetes, you're starting with, are you even testing for hemoglobin A1C? What percentage of your patients have you documented that test? And then into year 2, looking at the control of the hemoglobin A1C. What percentage of those are actually controlled, et cetera, over time. So again, just a big picture view, not to get into the details, but again, our goal is to ramp this up, phase this out over time, so the system and the health sector can get familiar with this. Many of these things they're already doing, maybe not documenting well. Many of these things they're doing, but they could do better, et cetera. Okay, so the transformation roadmap, again, we're not going to shock the system. Again, another graphic to say, once again, we have a phased approach. So this year, we're doing things around educating the sector. That's the spirit in which this seminar is given, to educate the sector and beginning to start selecting just a few KPIs going forward. Year 2, we'll focus on building capacity. Year 3, we'll focus on scaling. Years 3 and 4, scaling, and then start to benchmark because we'll have the robust and good data that we can trust, all the way to year 5, where we can talk about maybe expanding the program to other areas outside of the 5 conditions. So again, that's the rationale, that's the approach, and you've helped us inform this approach over time. So last 2 slides, what's the call to action? What do we need you to know? What do we want you to do? Well, we want you, number 1, to be aware of our 5-year strategic direction. right? Because we're an influencer in the health sector. Number two, we want you to begin to align with these 5 priority areas. If you're not focusing on diabetes and hypertension and smoking-related and coronary heart disease, we want you to start focusing on that more, because those are the drivers. Those are the high-cost, high-burden conditions. Those are the things that make it into our registry. Those are the things where we think we can get the most bang for the buck and the most juice for the squeeze, so to speak. Be innovative and collaborative in creating solutions. You're all very smart. You're working with different providers that are different levels. Partner with them. Partner with us. Be proactive. Ask a lot of questions. We need to know your pain points. We went through a process, myself and some of the team members, of having deep dive one-on-ones with all the insurance companies and TPAs. We did it over 3 weeks. We had 50 hours of interactive discussion about pain points and other things to inform this strategy. And then eventually over time, we expect and hope that everybody will be compliant. That's going to move the sector in the direction that we want to go. So what does that mean? That means beginning to start thinking about how you segment your high-risk beneficiaries, enhancing your health promotion and disease prevention. Dr. Shabab said moving towards prevention. It's a health sector transformation strategy, so we need to start doing that. In other words, not just be reactive, but be proactive. Not just be transactional, but be, again, proactive and preventative. Expand your operations on related to population health needs. Care managers and care coordinators. You cannot coordinate care without a care coordinator. Patients will fall through the cracks. So we need you to lean into that. Highlight your evidence-based practices on some of your compliance reports that we'll be asking for. And then obviously make sure your data is robust enough so that you can capture both clinical data and cost data, because those two things are what we need in terms of moving to value-based healthcare. And that's it. Thank you for your attention.
Thank you very much, Lamar. This is Hadi Al-Anizi. I'm the Chief Medical Officer at Cchi. I'll be moderating the session this morning. There is supposed to be a 10-minute break. However, we started late, so I ask your permission to proceed. And please feel free to grab a cup of coffee during this time. If you have housekeeping issue, we have around 400 people on the online. Please feel free to share your question through the online. We'll capture this question and we'll share it with the great audience here. The coffee break outside. The fire exit is through the door, downstairs. If something happens, I'll be first to run. So just follow me and you will be safe. If you have a question among the audience, we will gonna go through like 2 or 3 panels. Then we will pause for the question. I will start with introducing my great panelist. Dr. Ibrahim, we'll start with you. Please introduce yourself.
Good morning. I'm Ibrahim Omar, the Assistant Deputy for the Investment and also the General Supervisor for the PSP and VRO Office in Ministry of Health. First of all, I would like to thank the Cchi, Dr. Shabab and his team for inviting me to participate in this event. And I think what we have been listening in the introduction or presentations, it's value, information, and informative. But I will be making something different today. Always we are linking any strategic or thing. If it's not linked with implementation, it's useless strategy. So today, when we're talking about value-based healthcare, I would like to link it with economical health system. So today, if we look at to any health services or to have a very value health service, it should be linked with 4 main points. The first thing is that the availability of these services and the accessibility of this service is also efficiency and cost effectiveness, including the final is the quality of the service provided. So all these objectives or conditions for the value-based services, it should define before with 3 main categories. which is, or steps, it has to be defined the legislations and regulations on health system. Second thing is to have the well-defined operating models. Today, Dr. Lama is speaking about enhancing the primary care and also the prevention strategy program for the health systems and all these things. Third thing is the financing of these health services, and should be very clear defined. So I think with these main, I will say, steps, you can link with value-based healthcare system. Today, yes, we know that there is a transformation process taking place in Ministry of Health and within the Vision 2030, talking about Ministry of Health. We know that the ministry will not be anymore providing the service, it will be with the clusters. This is, we can define this as legislation, but it has also to link with another health providers, non-MOH providers, private sector providers. They have to be in the loop. Today it was mentioned by Dr. Lamar, there's 2% is the waste of the health budgeting. So it means, I'm expecting it's more than 2%. If we look at today, 20, yeah. So I was shocked. It's
We're trying to be conservative. Though.
Yeah. So that's the things that we should look at it. Today, yes, we can save a lot of these waste by defining very clear legislations, operating models, and very clear financing models. So today, what I want to conclude, it should be very clear map or journey of the value-based health services defined by these three stages or steps before we define the services and the accessibility or the availability of the fares to the populations. Thank you very much.
Thank you very much, Dr. Ibrahim. Lamar compressed 2 years' work in 10 minutes. And the CCHI decided to test how much you retain from the presentation. So please scan the question and answer it. If you can scan and answer, will be really good. We will get to the answers in a few minutes. Dr. Shabab promised with a surprise for the winner. Dr. Anna, you want to introduce yourself?
Good morning, everybody. It's really an exciting time to be in the healthcare sector in Saudi Arabia. I mean, just listening to what the plans of CCHI are for the future really makes us all feel really energized. So thank you for having me. It's a pleasure. I'm Rana Al-Mindil. I'm VP of Transformation Risk Management in the Health Sector Transformation Program, which is the newest vision realization program under Vision 2030. Thank you.
It's an honor to have you, Dr. Anna. Dr. Hussam?
Bismillahirrahmanirrahim. Dr. Hussam Ghunaim, I'm the Senior Healthcare Quality Consultant for the CCHI.
Thank you, Dr. Hussam. Dr. Lamar, you've been already introduced. Thank you very much. Dr. Hussein?
Assalamu alaikum. Hussein Reka, Senior Advisor with CCHI, and also part of this journey of transformation, one of a kind that I've witnessed since 2016, and it's a great pleasure and experience. Thank you.
Thank you very much. Dr. Nasser.
السلام عليكم. السلام عليكم. سعيد بالتواجد معكم اليوم. Very happy to be with you here today. My name is Nasser Al-Jahani. I'm the Associate Medical Director in CCHI. I'm also a family medicine consultant. I practice in the private sector. My other hat is I'm a clinical informatics consultant, and I work on projects related to technology and trying to make technology and people friends.
Thank you very much, Dr. Ada.
السلام عليكم. السلام عليكم. شكرا لاستضافتنا حقيقة. It's a pleasure to be here. I'm Rufayda Dabbagh. I'm an assistant professor and consultant of public health at Cchi University. And I had the pleasure also of working in the transformation for 2 years as a population health management lead at the second health cluster. So it's really nice to see that the transformation concepts and approaches are not really limited to the governmental health sector, but are rather, branching out. It's also nice to see really multidisciplinary action right here, because we're talking about, governmental health sector, private sector, providers working together. So I'm very happy to be here and looking forward to the discussion.
Pleasure to have you. Dr. Ada.
Assalamu alaikum, sabah al khair jami'an. Adel Gnabel, Director of Public Health Research and Advanced Analytics at the Public Health Authority. I thank the CCHI and Dr. Shabab for inviting me. I agree with my colleagues. It's very exciting to see this change, drastic change in healthcare in the country, whether it's in the private or governmental sector. It's exciting to see the importance of data. It was repeated today a number of times that we need data to evaluate healthcare and the cost of healthcare and the value of healthcare. So I'm happy to be part of this, and hopefully by the end of the day we can get you to even be more convinced why data is important to change and improve the health in the country. Thank you.
Thank you very much, Dr. Ibrahim.
Assalamu alaikum rahmatullah. Ibrahim Al-Jaffali, work as an advisor for pharmaceutical product at CCHI and also at the Program for Health Assurance and Purchasing at MOH. I'm happy to be part of this panel and happy to be engaged in this important event and being part of the journey for the last few months. Looking forward to a fruitful discussion and an enjoyable workshop. Thank you.
Thank you very much, Prof. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. I'm Ahmed Al-Jadai. I'm the Assistant Deputy Minister for Medical Support Services in the Ministry of Health. My background is a clinical pharmacist. I used to give hard time to people like Dr. Shabab for prescribing medications that have high costs with no proven value. So we'll be talking about this, Dr. Hadi, today, inshallah. I would like to commend the CCHI, the leadership of Dr. Shabab, for actually taking such a leapfrog in the healthcare when it comes to adopting the principle of value-based healthcare in everything that they do. And we're going to share some success stories. I've been working with the CCHI in really very important, successful stories that I think it's very important for many people to listen to and hopefully learn from, because we all learned throughout this journey. And I would like to actually thank you again for inviting me for this important panel discussion.
Thank you very much. Let me start with you, Dr. Ahmed. We raised the question about value-based healthcare. I think we did good for the answers. 70% of the people pick the quality, low-cost care. Is it high quality? Is it low-cost care? Can you help us, Dr. Ahmed, understand what is value-based healthcare?
Okay, great. That's a very good question, actually. Let's start with the 101 value-based healthcare. So value, I'm not going to add much to what Dr. Lamar mentioned, but value as a definition, in a very simplistic way of putting it, is the quality over the cost. But when you really look into it, it's not that simple, because quality encompasses a lot of things within the care to the patient. So this means diagnosing the patient with the right diagnosis, diagnosing it at the right time, offering them the best therapeutic options, using at the appropriate time, and at the same time adding to this the patient experience. So it's a very complex, even though it's a simple word, it's a very complex to achieve in reality. That's the quality. When it comes to the cost, it's not as simple as the cost of the intervention or the cost of the device or the cost of the, let's say, the medication. It's actually much more complex than this. It's actually more of the cost effectiveness, the cost benefit of the intervention. It's more of an economic model that could be built to see whether this intervention, whether it's a diagnostic intervention or a therapeutic intervention, is worth the money. So that's value. When it comes to value-based healthcare, the fancy definition of value-based healthcare is an infrastructure, or I would say it's a framework for restructuring the healthcare system with the ultimate goal of patient value. And the patient value, as we defined it a few minutes ago, is the value, the outcome per cost. And actually, Dr. Lamar mentioned very good examples that I hope we can have time to discuss in the next few hours. So basically, this concept was introduced in 2006 by Dr. Porter and Tisberg, and it was a new thing to everybody at that, during the mid-2000. However, we've been practicing certain aspects of value-based healthcare without coining the terminology of value-based healthcare. So again, when it comes to the definition of value-based healthcare, again, it's providing the best quality care, added to this the patient experience, with the best possible cost, not only the simple cost, but the overall cost on the healthcare system. And when it comes to adopting this principle here in Saudi Arabia, and we can hopefully discuss this in next few minutes, it's been actually out there in academic institutions, taught to medical schools and health colleges, but there haven't been implementations in real world until recently, when we started to see some value-based care initiatives. And Dr. Lamar actually shared some of the stories in the CCHI. I can share later some stories. But again, that cost that we're talking about is not how it's defined in the government, for example, when it comes to Ministry of Finance. So just to give a clarification to this point, Ministry of Finance, for example, provides budget to all governmental agencies and ministries based on chapters. Recently, this was revised several years ago, but it still depends on different chapters. So you have budget for salaries, you have budget for equipment, you have budget for capital equipment, and so on. So, for example, when it comes to medications, you have a budget specific for medications and medical supplies, okay? When we are talking about the costs in value-based healthcare, we're not talking about that particular cost of the medication. We're talking about the overall cost. The national healthcare system is going to be impacted by when you introduce such diagnostic procedure or a therapeutic intervention. So when you say I'm going to give a medication for prevention, which is one of the goals for the VRP that you mentioned, or that Dr. Shabab mentioned actually in his talk, that particular cost is taken from a medication. However, the impact on prevention of hospital admission, prevention of ER visit, percutaneous catheterization intervention, prevention of stroke, disability, rehab, all of these things are not captured within the chapter where that particular cost was taken from. So it's very important when we talk about implementing value-based healthcare here is not to focus on the acquisition cost of the intervention, rather the overall impact on healthcare system.
Thank you very much. Can you pose the second question, please, Nada? So we heard a lot of terms today mentioned when it comes to achieving the value-based healthcare, the population health. And we heard a lot about public health, about population health management. These concepts can be a little bit confusing. Dr. Lamar, would you help us clarify these definition? Meanwhile, please have a look at the scan it, and let's see what you think of the population health versus public health. Dr. Lamar, are they the same?
Should we wait on the poll, or?
I think we can start, and we'll see how
okay, great. So, yeah, thank you. Great question, and it is a source of confusion for many. And to sum it up, population health, the definition depends on where you sit. As they often say, where you stand depends on where you sit. But population health, quite literally, is the health of a population or the health of a group of people. So it really is a descriptor. When we say population health, we're describing the health of a specific population. And quite literally, it is what is the health of that group of individuals, the distribution of health among that group of individuals, and kind of the determinants or social determinants of the health outcomes and policies that impact those social determinants within that group of individuals. So as you can see from the definition, you really have to start with defining the population. Population could be everybody at this seminar. Population could be my patient panel. Population can be all the people that live in cluster 10. So you can define the population in multiple different ways, but at the end of the day, when we say population health, we're really referring to what is the health of that group of people, the mortality, the morbidity, the hospitalization rate, you know, the preventable hospitalization rate, the health behaviors, et cetera. Now, where it gets confusing, I think, is that, let's see here. So we have health of a geographic area. That's one way that you can define population health. General public is not the right answer because you have to define a population either in a regional way or in a geographic way or a discrete way. And the general population is not discrete enough. Health of the beneficiaries could be true. It's how we're defining population health. That's how we're defining our population of concern is the 10, 11 million beneficiaries that we help to care for. And then the triple aim is not the right answer, but it is something that brought this, this term to fore. It's made this a rallying call for many because the triple aim, which focuses on decreasing cost, improving the patient experience, and improving population health, or the health of a defined population, really kind of gave this term traction. So where it gets sticky is that there can be many activities or initiatives directed at improving the population health. And these can be done by many actors. Public health authority can be a very important actor. In fact, some would say there's 4 pillars of action to population health. And one is public health. The other might be policies. The other might be chronic care management. And the other would be population health management, which we talked about. So that's kind of population health. Now it means that any actor, a civic society, business, can do activities directed at improving the population health. So we can all have a role in improving the population health. The question is, what population are we defining, and at what level are we working with our initiative to improve population health? So I hope that's helpful.
That was helpful. Dr. Rafaida, would you add a little bit more clarification for the 2 terms?
I don't know if this is working. Oh, yeah. Thank you very much, I think Dr. Lamar explained very beautifully, really. There is a lot of confusion, as he said, about the difference between public health, population health, and population health management. And I think one of the problems is the way it is described in the literature, really. So sometimes, I mean, if you're looking at healthcare literature, healthcare management literature, most probably when they use the word population health, they're talking about population health management, although they don't necessarily have to say the whole, term. The way I would like to see population health management described is it's really a system where you have a very robust way of identifying the highest risk of your population and their needs, and then applying the interventions to those specific groups, to those specific needs, in order to achieve the triple aim like Dr. Lamar just mentioned. The term population health management is really very heavily linked to, when you're talking about integrated care or accountable care organizations, all that kind of stuff. And so really when you're talking about population health management, you're talking about an approach or a system for you to have a very robust way of applying value-based care in your healthcare system in order to improve the triple aim. As Dr. Lamar said, public health is a very important tool to have to achieve population health management, because if you're talking about population health management, it's really revamping your original, fee-for-service healthcare system in a way that really targets the group of people in your population so that the services are provided across the health continuum, and not only as Dr. Lamar also said it in his presentation, not only as a reactive healthcare system, but really a proactive. So we really want to identify the healthy population, which is usually in any population, it's the healthy majority. It's the majority of your population are healthy people who really don't access healthcare delivery services unless they have an emergency. So usually if they have a, an accident or something like that. So those people you really want to interact with and make sure to keep them healthy to prevent chronic disease in the future. Then you've got, in the middle, you've got the people who are at high risk for having diseases, but they don't have the disease. You want to target those people too. You have the people who are high risk and who already developed chronic diseases. So you want to really focus on the secondary care, prevent disability. And then you've got the people who are very little portion of your population. However, they really cost you the most because they have recurrent ER visits, recurrent admissions. They need, end-of-life care, for example, or home care and all that kind of stuff. So if you have a robust population health management model to apply to your healthcare system, you would be able to identify all those different groups and apply the interventions that those people need the most in a way that reduces the waste, your medical waste, and improves your outcomes, reduces the costs of care.
Excellent. So to summarize, it is a well-prescribed, described sector of the population with certain outcomes you are looking for with a certain intervention.
Absolutely, yes.
Great. So I would imagine, Dr. Lamar, such approach will require lots of resources. So for us to be successful in executing our population health for the 5x5, what kind of resources we need to be aware as a healthcare community and industry?
Great. So, I'm smiling at myself because I keep getting these questions because I'm kind of the population health guy of the team. If you hadn't picked up on that background in public health for 20 years or so. But before I get to that, I just wanted to clarify one other thing. So public health is uniquely different in other ways as well. And I just wanted to say, one, it's usually publicly funded. So it's a part of what we call the social contract. The government pays for it. Two, there's different practitioners in public health. So you'll find your researchers, your epidemiologists, your environmental health folks, your statisticians, biostatisticians. So there's other types of cadres of professionals there. So that's important as well. And here, obviously, in the kingdom, Wakaya and in the Ministry of Health serve that function. So it's a little bit different and distinct in that way as well. And we look at public health as really helping to make the conditions in the environment for folks to have the opportunity to be healthy. So they're working in promotion and prevention and other things like that, your COVID vaccinations and things. So that's a distinction. Now, in terms of the resources that you need, so if you want to improve the health of the population, it really just depends on your perspective. If you're coming from a civic organization, if you're coming from academia, you can make different contributions. If you want to focus squarely on population health management as defined in terms of looking at that high-risk group that you really want to focus in on, you need two main buckets of tools. One, you need a data system because you have to track both the clinical data and you have to track the cost data. And there are platforms that can integrate with your EHR that allow you to collect that data. So you need the data system. Secondly, you need the team. And this is where we talk about a team-based care, because not just one person, the physician, the pharmacist. No, you need the physician, the pharmacist, the care coordinator, the care manager, the nurse, the health coach, the nutritionist. So it's a team-based concept. So you got to have your data system together. You got to have your clinical management team together so that you're working with this patient population, this discrete population as you defined it over time to meet those outcomes. So those are the two main resources. And two resources that we at Cchi are sponsoring is we have a white paper on population health management that's going to be released very soon. And we also are putting together a compendium of resources, things like EHR and data platforms and things that folks can use to draw down on as they begin this journey of transformation. So look for Cchi to have those out in the field in the sector very soon.
Thank you very much. So this was an advertisement for the white paper. Please stay tuned for it. So two things to summarize what Lamar mentioned: the team-based approach and the digital and data management. Dr. Ada, tell us about the digital requirement or role of data in the population health.
Shukran, Doctor. Okay, so as you heard repeatedly, most of this is based on data. So if we wanted to establish a system that pertains to the Saudi population, for it to be population-based, Am I clear now? Okay. So it's based on data. So in other words, we can't just take what's done in the US or the UK or Canada and adapt it in Saudi Arabia. We have a different population. And as Dr. Lamar said, the attributes of the population is based on how we define it. And so that is derived from data. One of the examples we saw of the lack of data, when he talked about cost, there is no cost for the Saudi waste. There's an exclamation mark. If you look at different aspects of health or statistics that pertain to the country, again, you will see varies of level of data that's available. So in other words, that will affect how we actually divide the resources in the country. If we're not sure how the different diseases perform, is it different? Is it the same? We had the 5 diseases or risk factors that were talked about: diabetes, hypertension, etc. Again, we use estimates that are probably from different countries of the world when it comes to treatment, screening. But is that adaptable to our country? Is that the most value-based, the best value or the best bang for a buck? Do we need to screen earlier? Do we need to treat earlier? Do we need to follow up more often? All of these are questions that can be captured using digital health. Digital health is using electronic health records. This is a massive amount of data. It collects numerous data points throughout time. It collects different variables for each patient, and it collects a number of patients. So when you categorize, when you use this data statistically, epidemiologically, then you're able to say, based on the evidence in the country, this is how we modify our strategy, this is how we modify the clinical pathways, and this is how we reduce cost. Now the issue, or one of the challenges we face, one, this is a bit new in the country. 2, there's the issue of quality. So data is not just the volume of the data. We've heard again, yeah, okay, I think I'm still there. So the quality of the data, and this is where the role of the different health sectors, the insurance companies and the CCHI, the Ministry of Health, all of the involved stakeholders can and are asked to be participants and to be champions for this part. Because if we don't have the quality of the data, even if you have massive data, then there's an issue with the estimates we predict or the conclusions we are able to reach. So it's not one person, it's not one entity. However, the output, the benefits of having a rigorous, a robust electronic health record system in the country is enormous. Whether it's on improving health, or if it's on improving and reducing the cost. Because these are chronic diseases, so we know the cost of these diseases is quite high. However, we need to be patient, because in order to modify them, to improve them, we may have to spend some money to gain some money at the end. And without data to follow this up and to actually estimate whether these interventions, preventions are successful, we cannot modify our way of treatment. And so again, when we talk about education, when it comes to diabetes or hypertension, which is one of the areas that there's a lot of investment, what type of education? Is it similar to what we do in other countries to the Saudi population, or do we need to modify it according to the needs of the Saudi population? And I think that is very essential for us to be more successful in our efforts in order to improve quality of health and also reduce the cost of health. Thank you.
Thank you very much. Dr. Nasr, I think we can't leave the talking about the data and the EHR without mentioning something about one of the enablers that CCHI is leading, which is Nafis. Would you share with us a few things about Nafis?
Assalamu alaikum. Yeah, I think one of the biggest important enablers for value-based healthcare, and also one of the biggest challenges today that we have in the healthcare system is lack of data. And that's why Nafis has been a tremendous and very big project that has been supported in order to help us transform our healthcare. It's a very big challenge that we lack data today, and for population health management, and that's why we have these phases that Lamar presented, because we believe the market is not mature today in order to execute all the population health management goals. And in order for us to achieve population health management full program and execute, we need the market to be mature. And to mature, one of the biggest infrastructure is data. So Nafis, in a nutshell, is a platform that's going to unify all the, or sharing all the data in the kingdom. It has 2 very important components. One is the financial transactions that are happening. This is where we can track claims, cost. We understand the where patients, what patients are visiting, what their encounters in the healthcare system, have they been admitted, ER visits, clinics, what medications have been prescribed, etc. And then the other aspect or the other section is the clinical, which where we can identify the diagnosis, we can identify these patients, the diabetics, what happened to them, what lab orders have been done, what lab results have been done, where they have been taken care of. And so I think I'm very happy that we are starting the discussion about population health and setting up the stage, because this is going in parallel with Nafis. And I believe in 5 years we will start to see the interlinking between the population health and the use of data and Nafis, and where we get to a more mature stage at that stage.
Thank you very much. One of the two items mentioned by Lamar is the data, and the other one is the team-based approach. And we know one of the major team-based approach is going to come around the concept of primary care. So we thrown this question about how you best describe primary care, and take a moment if you haven't participated, and let's see what you think of your understanding of primary care. Okay, so I think we can go to the next important topic about the team care-based approach. But before we go, I want to talk to the person who chose number C, hospital healthcare provider. Please see me after the break. We need to talk. Meanwhile, Nasser, would you please tell us about the role of a primary healthcare in population health management, how they are linked together?
Yes, excellent. I'm very happy you asked this question. So, population health management as a concept, it has been mentioned many times, I'm not going to repeat, but it's basically you start with your goal. What are you trying to achieve? In our situation, value-based care, right? So we want to improve quality and reduce costs. So we identify the diseases that are high burden, diabetes, hypertension, etc. And then you identify your population, and then you execute your interventions, or identify your interventions and execute, and then you monitor the outcomes and see if you've been able to do any changes or improve the outcomes for the patients. So this is as a concept. Now, you need to execute this. So in order to execute, the way we envision how this is going to be done is you're going to have an entity that's going to be accountable for this and supervising and monitoring this, and then you need an entity that's going to execute the interventions that you're applying. So if we want to achieve value-based healthcare and improve that quality with maintaining cost or reducing costs, you really need a cost-effective way. And the most cost-effective way in our healthcare delivery today is primary care. Because one, it takes much shorter time to train primary care staff, physicians, nurses, administrative staff. It takes much shorter time to build the primary care center or even a primary care floor in a building. And the equipment and the procedure that you need in primary care are very minimal. So we believe that population health management is better executed through primary care, because that's the most cost-effective way. And that's why we identified this as a very high priority project in CCHI, and we have a primary care strategy that we are working on in alignment with population health management.
Thank you very much. Before I go to the next point, is there any question from the audience here? Okay. Sam.
How can we move faster, ladies and gentlemen? 5 years for population are too long. You know, public expectation is always things will happen effective immediate. So can we do it faster?
Can we do it faster? We won't accept no as an answer. Tell us how we can move faster. Yeah, Doctora.
Yeah. Thank you very much for this question. Okay, so the honest answer is, unfortunately, there is no way to move faster if you've just started, really. And the really thing about transformation in healthcare in general is that it's a very long process. It needs a lot of patience. It's a messy process, really, and you have to, anticipate the messiness, the bumps that you face along the way. You're always going to have a plan, but it's always going to be, disrupted at some point. You need to invest a lot of money at the beginning, a lot of money. However, on the long term, you're going to save the money because you're going to improve the health of the population, you're going to try to prevent all of the chronic conditions that are really costing or overburdening your health system. So I would say maybe it would move slowly at the beginning, but if you've invested your time, your effort, your capabilities, capability building is a really important thing again, then it's going to be faster and you might, be able to it will be autopilot, as they say, after this.
I believe the speed of the execution of this program is going to depend on the maturity of the market. This is number one. If the market is mature, we can move much faster. Now we have set the strategy and the expectation. I think we're going to see a lot of people starting to invest and think about how to hop on, and this will probably accelerate over the next coming years. So now people know there is a direction. So one is going to depend on the maturity. We're hoping people to start to accelerate their investment and work on population health management. Two is what Lamar, I think, mentioned. We don't want to shock the system. We don't want to cause extreme changes or fast changes. We want this to be a smooth change to the market. We know there are a lot of investment that have been done over the last years, and people have expectations for the next 5 to 10 years. So we want this to be smooth. So I think the speed will depend on the resistance and the amount of disruption that we don't want to cause. We want this to be a transformation, not a market.
I think we can move faster. And the way I look at it, it's not the percentage of completing the multiple phases or finishing before the timeline. Rather, I think we need to focus on two things. And if we can achieve these two things, I think the implementation and the impact will be measured faster, will be felt faster by the public and by the government and by all stakeholders. Number one is you have to have a reward for all stakeholders, including the patient, insurance companies, providers, policymakers, everybody. You have to have the carrot. Find the carrot, give it to everybody, show them that this is what they are going to benefit from when you implement such programs, and everybody will jump to the driver's seat and drive faster. I think this is a very important key point, that if we want something like this at a national level, we really have to show the reward, number one. Number two, focus on just what Lamar mentioned, high value, high burden, and high impact areas, diseases, for example. Diabetes and obesity, for example, are major comorbidities here in Saudi Arabia. Rather than starting with national screening of some genetic disease, for example, which might be very expensive, it might take some time, and the impact on the public might not be the same as a prevalent disease such as diabetes or obesity. On the other hand, managing the maturity of the market that Dr. Nasser mentioned with regards to obesity and diabetes diagnosis and management, education, is actually much more mature than other less prevalent diseases. So I think if we hit these two factors, we could implement more valuable initiatives that will have higher impact on the public.
So if I want to summarize the two, find the common goal, the driver for different parties, and the other one is find the high-stake conditions.
Exactly.
So aligning the priorities, basically.
Exactly.
Okay, Dr.
Shukran. I agree with that, have said, but also I think moving slowly and surely, I think Lamar and Dr. Nasser also mentioned that, explaining what are the wins. So if we establish a registry that's successful, that's a win. We may not reduce premature mortality at this point of time, but if we're able to screen for hypertension and say this is the number of hypertensives within a year that were identified through the system, in itself that's a win, because we know screening for hypertension will reduce the mortality in the country by 30%, but it's not going to happen tomorrow or the day after. So I think also understanding the nature of the diseases we're focusing on and the wins that happen through time, but not necessarily today by reducing mortality, is important for the stakeholders and the non-health maybe stakeholders that may not understand or grasp that you cannot change the nature of the disease within a year or two. That's not possible. But also recognizing the wins that the health sector, the insurance sector are able to accomplish with all these changes that they're trying to implement.
Thank you very much. Dr. Ibrahim.
Just a quick comment that we are now moving from a design phase to an implementation phase. So we have a lot of assumption. We have a lot of expectation from the market, and we thought that the market will not adapt very quickly to some of the initiative. So I think now, instead of focusing on redesigning or probably accelerating, is to start implementation. And then we can test exactly our plan every 6 months or every year. Maybe we can push the accelerator a little bit harder on some of the initiatives to achieve a better outcome. Or sometimes we can slow down because the market reacted differently than what we thought at the design phase. So I think the key to accelerate is actually close monitoring to the implementation phase. Not necessarily redesign, but at least rethink how we can push some of the initiative faster. Could be done every 6 months, just to look again into the initiative and the timeline and how we can actually shorten the timeline required for some of the initiative to be implemented on the ground.
Please go ahead.
I would like to focus on the point that I mentioned before and was mentioned also by other respected panelists. I think people need to see what is it in for them, including the patient. Now, an example is the car insurance. If you renew with a company, you get the same company, you get a special discount. If you haven't had an accident over the insurance period, you get a discount. If you do the annual checkup for your car, you get a discount, and so on. So the patient needs to know what is it in for them. And if we are going to implement primary care at a large level and expect people to just know what is it in for them without really coming forward and explaining this to them and sharing with them the benefit and offering them the wins, we're not going to move faster. So it's the same thing. We could develop a system where we say, if you go and check your blood pressure and blood sugar and fasting lipid profile every 6 months, for example, which actually very cheap now for certain patient category or patient age, then you get a discount in your premium in the insurance policy. Same thing, if you quit smoking, then your insurance policy will go down by such and such. If you lose that much weight or BMI, then your insurance policy will go down by such and such, and so on. I think this will show the patients, and we can do the same thing with other stakeholders, insurance companies, providers, and others. By doing this, you're encouraging everybody to believe in the idea, but also put practical steps into adopting the principle.
So, Dr. Ahmed, you are leaning to the innovation and how we do it, the innovation in healthcare, the innovation in payment, the innovation in engaging the population and the stakeholders. That will take us to the next question, Hussein. What are some of the innovation that CCHI or the industry is considering to help us move or accelerate how fast we can move?